Auzubillahi minash shaitanir rajim. Bismillahir Rahmanir Rahim. Kul huwallahu ahad, Allahu samad, lam yalid wa lam yulad, wa lam yakul lahu kufuwan ahad. Sadaqallahul Azim. Assalamu alaikum and a very good morning to all the participants who have joined this scientific session. I'm Dr. Faraz Ahmed and I'm a fellow in neonatology at the Indus Hospital and Health Network. I am pleased to be moderator of this session today. As we know that one of the most common problems that we come across in newborns are respiratory problems. The main goal of this session is to enhance the knowledge of neonatologists, pediatricians, residents, fellows, and all the doctors who are dealing with those newborns with respiratory illnesses. For this reason, there is a very exciting list of topics planned, including that I know would be wonderful series of lectures by renowned neonatologists who have worked both at national and international level. First lecture would be on labor room management by Dr. Junaid Mohib, followed by choice of surfactant by Professor Talal Waqar. Next in line would be Professor Irfan Waheed, who will present a high flow oxygen therapy. And lastly, Dr. Yasir Masood will talk on caffeine. Each speaker will have 30 minutes each, and the audience can ask questions in Q&A section on the right side of the screen. And it is requested to all participants to please fill in the feedback form at the end of each talk in order to receive their e-certificates. Before we start our session, I would like to invite Dr. Syed Rehan Ali, Senior Consultant Neonatologist and Head of Department of Neonatology at the Indus Hospital and Health Network, for his welcome note. Dr. Rehan.
We have, Faraz, we have enough joining, and audience can they hear me? Can you hear me, Faraz?
Yes, sir, I can hear you.
Okay. I welcome all of you in this eminent session on this very important topics, which will be presented by to us. Junaid he's been trained in USA and spent most of his life in USA and Abu Dhabi, and he's currently working at Sheikh Shakhbout Medical City in Abu Dhabi. Junaid has a vast experience in neonatology. He has been over to us on several occasions in
I guess there has some internet issues on Dr. Rehan's side. Thank you so much, sir. Moving on, as you gave a brief intro of Dr. Junaid Mohib Khan, he's our first speaker. Dr. Junaid is American board certified in pediatrics and neonatal and perinatal medicine. He is currently working as Director of Medical Education, Senior Consultant in Neonatology, and Associate Director of Residency Program in SSMC Mayo Clinic, UAE. He is Fellow of American Academy of Pediatrics and Fellow of Royal College of Physicians, Canada. He is an active member of Committee of Neuroresuscitation Program. He has vast experience in medical education. He is a visiting faculty in Pakistan and Canada. He has presented at many national and international conferences as a speaker. Dr. Junaid will talk about optimal management of neonates in labor room that can improve respiratory outcome. Over to you, sir.
Thank you very much to take me on this esteemed conference, Icon 2022. Is still because of pandemic, we cannot see each other or meet each other physically, but hope for the best, inshallah. Very soon we start our usual meeting. So the topic today I'm going to discuss is the delivery room handling of the newborn, and I will give you some updates regarding that. I have nothing to disclose. Uh, First of all, we have to see the stabilization versus resuscitation. 90% of our babies do not need any kind of a resuscitation, and luckily they just need our help for stabilization. So always remember more observation and the less aggression. As you can see, this is the data pre-COVID. Around 136 million baby born all over the world. And as you can see here, all of them required some kind of a support, but only zero point 0.1 million required the volume expansion, so they are very sick. Now, the ILCOR, the International Legion Committee on Resuscitation, which I am also the member, recommend the new neonatal resuscitation and the new guideline how we act in the delivery room. And in this time, they also give the class of recommendation and level of the evidence, which is very important to understand. And I will go through each of that in coming slides. So these are the algorithm which we have to follow, and these are the new algorithm 2021, and this is the new form that how we deal the babies in our delivery room. Start with the pre-birth questions. There are four pre-birth questions: before, gestational age, amniotic fluid clear, how many babies, additional risk factor. Now it changed to amniotic gestational age, amniotic fluid, additional risk factors, and umbilical cord management plan. How many babies is gone? So now you have to prepare and to talk to the parents about the umbilical cord management and why it is important. I will go through it. So the additional risk factors should continue the question which is deleted from the last edition, how many babies. Now, delayed umbilical cord is a very important um, uh, thing to do. We shouldn't clamp the cord immediately. And the reason is very obvious because it helps the baby in many ways. First of all, as you can see here, the saturation, the black is immediate cord clamping, blue is delayed cord clamping. As you can see here, the immediate cord clamping delay the saturation to reach up to 90, for example, 4 minutes, but the delayed cord clamping reach the saturation is 80% at 1 minute of life. Similarly, the heart rate with delayed cord clamping is higher as compared to the uh, immediate cord clamping. So it is not only that, there are many other advantages. For example, the preterm infant have less IVH, intraventricular hemorrhage, iron stores are high, blood transfusion needs is less, decreased need for resuscitation. So there are many, many advantages, and it's very well evidence, which I'm going to show you in a minute. Now there's one thing which is go against the delayed cord clamping is the symptomatic polycythemia, increased jaundice, but there is no evidence. It's just a plausible theory that it can happen, but there is no evidence. So the recommendation is to delay cord clamping even for the preterm infants. And these are the meta-analysis which we can refer from January 2018 from American Journal of OBGYN, and it has show you that it favors the delayed cord clamping, as you can see here. Now, the cord milk and this milking and the stripping is the another thing which we talk about it, but there is no evidence that it is better. So, the no difference in the rate of death, no data of neurodevelopment, no difference in use of phototherapy, but the low quality evidence shows that there is a reduction in the rates of all the IVH. But in 2020, which is the hallmark paper on that subject, showed that this is the in preterm infant, it can cause increase in IVF. So the suggestion is to against the routine use of cord milking of the infant born less than 28 weeks. So please do not do the cord milking less than 28 weeks of life. And there's a many meta-analysis in favor of delayed cord clamping as compared to the umbilical cord milking, as you can see here. The reason is that you can see what will happen during the cord milking. So this is first milking. This is the carotid artery blood pressure. This is the net umbilical blood flow, and this is the carotid artery blood flow. As soon as you are doing the first milking, second milking, you can see the variation in the blood flow and the carotid artery blood pressure, which can lead to the intraventricular hemorrhage. So in a small baby younger than 28, 29 weeks, please do not do the cord milk stripping. Yes, you can do the delayed cord clamping. In which condition we shouldn't do that delayed cord clamping? When we have the placental circulation is not intact. For example, abruptio placenta, placenta previa, cord avulsion, and so on and so forth. Multiple gestations, because we don't have the data that twins, triplets, or quadruplets, how they react to delayed cord clamping. So the recommendation in those conditions, obviously in placental circulation is not intact. So why? What is the reason? Because placenta is already detached. So there is no point to delayed cord clamping. But in multiple gestations also, we shouldn't do the delayed cord clamping. The third one, if the baby is not vigorous. So if the baby is not vigorous, then of course, uh, here, who are not vigorous, you have to resuscitate the baby as soon as possible. So defer the delayed cord clamping. Now come to the initial steps. So antenatal counseling, pre-briefing, and all this happen. Then you have to see the term that if the baby has term gestation, good tone, and breathing or crying. So these are the three questions you should ask yourself. If the baby is term gestation and have a good tone, crying and breathing, then everything fine. Give it to the mother, and that's it. But let's say if the answer to these questions is no, then we have to do the initial step, which is the warm, dry, stimulate, position airway section if needed. So how you assess that? So in breathing, there are three things: good effort, inadequate effort, and no breathing. In heart rate, fast heart rate, which is normal more than 100 to 120, slow means 60 to 100, and very slow less than 60 per minute. SS tone, the good tone, inadequate tone, or the floppy. So if any one of those yellow and reds, then you go to the next step, which is warm, dry, stimulate, position airway section if needed. So this is the next step you have to do accordingly. In the meantime, the temperature control is very important because there are 36 observational studies showed that if it can increase the risk of mortality if you cannot control the temperature and the baby has hypothermia. So the recommendation is to maintain the temperature in the delivery room or in the C-section room is about 36.5 to 37.5 centigrade, and it is a very strong recommendation with low quality evidence, but the recommendation is very strong. Why it is? Because cold stress can cause the apnea, decreased surfactant function, increased metabolic acidosis, lower pH, and may reduce the pulmonary artery relaxation, which can lead to the persistent pulmonary hypertension. Maintaining the temperature in preterm infant is very important. Strategies available for that, and you have a warmer, you have a warm blankets, you can do that, and in less than 32 weeks, you just have to wrap the baby in the plastic wrap. So please maintain the temperature, and this is the very high quality evidence. Class of recommendation is 1, level of evidence is B, and it shows in many studies that you have to maintain the temperature. Now, 36.3 to 37.5 degrees centigrade for the baby. Ambient temperature is 24 to 27 degrees centigrade. Ideally, it has to be 26 degree and not less than that. So your ambience temperature, your room temperature should be 26 around, and your baby temperature should be maintained 36.3 to 37.5. Then you do the tactile stimulation to the baby, because the baby is not breathing or not crying. It has to be gentle, just drying the infant, just rub the back and do it very gently. Avoid more aggressive methods of stimulation, which is can cause harm to the babies. Suctioning is only required if needed. So 10 to 15 seconds, if the baby is not breathing, just give a time. It doesn't mean that you start deep suctioning. So avoid deep suctioning during the first 5 minutes of the life. And the class of recommendation is 3, which is the orange. There is no benefit. After that is the harm to the baby. The reason why we are doing that, if you see that study, that minutes to 86 saturation in a non-section baby is 5, in a section baby is 8.2. Minutes to 92% saturation reach is 6.8 in non-section, and section is 10.2. So that's it delayed to reach the desired saturation. So please do not do the unnecessary section in the babies. So here is the algorithm. So we are here now. The baby, you did the warm, dry, stimulate, and everything is fine. If the baby is breathing fine, then of course give it to the mother. If not, then we go to the next step. So airways is the next step, is stabilization and the sectioning. As we mentioned, that we don't do the routine sectioning. If the baby is non-vigorous and born with the meconium-stained amniotic fluid, the recommendation is the same. Do not do the suction and try to clear the airways with the meconium and all those stuff with intubate again and again. It causes injuries. It can delay the oxygenation of the baby, the delayed the positive pressure ventilation and the trauma. So please do not do that. Just start the positive pressure ventilation with your embu mask or the neopuff if you have it. So do not delay the positive pressure ventilation in your delivery room if the baby born non-vigorous with the meconium stained amniotic fluid. The section through the from the trachea is over. We are not recommending it. Now come to the ventilation. After doing all this thing, let's say the baby requires some support. We have to give the ventilation, the oxygen concentrations, how much we put. I will come all in the next few slides. We have to give the ventilation through the mask or the neopuff, but we have to know that there should be no mask leak. So the pressure, the flow, and the volume should be in harmony or in synchrony. But if you have a large mask leak, you can see the volume is all over the place, the pressure is all over the place. If it is obstruction, then it is also all over the place. So either you can develop your skill through the mask ventilation, or the another thing you can put this, cut the ET tube, put it into the nasopharynx, and you can give the desired positive pressure ventilation. And why we are saying that? Because when we did this study, and it shows that there is no adverse events observed, both interface are appropriate. So either do by the mask or by the nasopharyngeal tube, anything, whatever you feel comfortable, you should use it. This is you have to develop your skills, because if there is a large leak or the obstruction, then you cannot provide any benefit to the baby. We have to be very careful, because at that step, as I said, 99.8 or 98% babies recover and they don't require further management. Assisted device, they now added up. We have to develop a skill. We have to procure the laryngeal mask. And the laryngeal mask, it's any baby more than 34 weeks. We can use it if you are not comfortable with intubation. What is the laryngeal mask? As you can see here, these are the two types of laryngeal mask. You just advance through the oral cavity up to the oropharynx cavity, and then this opening facing toward the trachea so that the baby can get the positive pressure ventilation. It is very easy to do it, and it is, sorry about that, it is available now. So if the baby is more than 1500 gram or 34-week gestation, you can use it if you are not comfortable and if the baby required further resuscitation. Now, sometimes we are doing all things rightly, but maybe because of some adjustment the baby need, and we use this mnemonic with Mr. Sopa, M for mask adjustment, and the R for reposition of the head and neck. After doing this, just give the 5 breaths and assess the chest movement. If no chest movement, do the next step, which is the S, section the mouth and nose and open the mouth. Again, after that, after each and every step, you give the 5 breath and assess the chest movement. If not, then you can increase some pressure and then assess again and give the 5 breaths. So these are the steps we are going in a stepwise approach to help our baby out. So MR, give 5 breath, then SO, give 5 breath, then P, and then use alternate airway, which is the laryngeal mask or endotracheal tube, if you are comfortable with that. So these are the all corrective steps in the diagrammatic form. It is very easy to remember. So now we reach up to here that baby requires some ventilation, baby requires some extra support. Then how we proceed further. Then we have to check the heart rate. Now the heart rate, as I told you before, if the heart rate more than 100 is satisfactory, the baby is fine, baby is breathing, that's it, you don't have to do anything. But if the heart rate is slow, 60 to 100, then it means that it is possible hypoxia, or if it is very slow, less than 60, then you have a critical hypoxia. At this point, you have to have an alternative airway and you have to have monitors attached. It is better to have a pulse monitor to attach. They recommend the ECG, EKG monitoring also, but most of the places we don't have, so don't worry about that. Pulse oximeter is more than enough. If just give us some time, it will give you the correct heart rate. So as I showed here, the heart rate reach 100 at 1 minute, and it is 50 percentile. So it take about 1 minute to reach the 100, which is the 50th percentile. So wait up to that time before you do any action. Now, what do you mean by the adequate heart response? So let's say you are doing your positive pressure ventilation. Let's say you are doing everything right, and then you are checking your heart rate. So what is the meaning of adequate heart rate response? The increasing heart rate is the primary sign of the effective ventilation or the effective effort you are doing to the baby. And the adequate heart rate response means 20 beats per minute, the first 30 seconds of the ventilation. So let's say you start the positive pressure ventilation and the heart rate was 80, it reached to 100 in 30 seconds. It means you effort, your positive pressure ventilation effectiveness is good and you are doing in a right way. If you are not achieving that much, then it means something wrong going on. You go back and adjust the mask, adjust the position as Mr. Sopa guided you. So again, the 20 beats per minute, the first 30 seconds of the ventilation or positive pressure ventilation, your heart rate should respond. Next is the oxygenation. Let's say that this is a lot of debate on the oxygenation. We know that now start with the room air if it is the full-term baby, rather than 100% oxygen. But most of the centers in Pakistan do not have the blenders. Unfortunately, we have to stay whatever they have, that through direct from the cylinders, we have to give the oxygenation. But ideally, I have to tell you that how we can do the oxygenation. So again, you don't have to jump that the baby delivered and start oxygenation 100%. It take at least 10 minutes to reach 85 to 95%. And this is the very important, and it is come into your algorithm also here. So 10 minutes to 85 to 95%. Please do not push the baby to give too much oxygen before that time reach. Okay. Now, another thing, they add up the box that if the baby is more than 35 weeks, then start with 21% oxygen. If it is less than 35 weeks, then you can start from 21 to 30% oxygen. But if you have the blenders, you can adjust easily. But if you don't have the blender, then it is very difficult to reach. And whatever you have, you should continue to do that. So this is the blender which I am talking about. It has two pipes coming. One is air, one is oxygen, and then you can adjust the dial accordingly. As I said, that if it is a full-term baby, put him on 21%. If it is uh, less than 35, you can start from 21 to 30% anywhere, but not more than that. Now, how you maintain it? So, if the baby is breathing or is well ventilated and heart rate is rising and the saturation is more than 10 percentile, as I showed you the graph, the oxygen is not required. If oxygen is needed, FiO2 should be titrated and keep it more than 10 and less than 90th percentile. If the saturation less than 10 percentile, then you increase the FiO2. As soon as you reach that more than 10 percentile, then start reducing the FiO2. FiO2 is, or oxygen is a medicine, so please be careful of that. So this is the recommendation, that more than 35 weeks, 21%, 28 to 35 weeks, 21 to 30%. And if the baby less than 28 weeks, then start with 30%. But again, you cannot reach that if you don't have the blender. So whatever you have, you try to modify it accordingly. The next is the circulation. Circulation is the same, that if the baby needs chest compression, if the heart rate is not improving at 60 or less, then you start the chest compression. Compressions is start with 3:1 ratio, that is 90 to 30 events. This is no human data. This is all animal studies, but we are performing the same 3:1 ratio. The only thing is nowadays recommended is to do the two thumb technique as compared to the the two finger technique. And the reason is the depth is better in two thumb technique, and the variability is not that much as compared to two finger technique. To try to do the compression by the two thumb method as shown here in this photograph. The most important thing which many of us forgetting during the delivery room, that if the baby reach the point that we need a chest compression, then you have to give the 100% oxygen to the baby. And as you can see here, this is the dial is on the 100%, then you have to continue your chest compression. The reason is that oxygenation to the brain is appropriate if the 100% oxygen as compared to 21% or any of the other number. So please put the baby on 100% oxygen. If you reach the point, it means your baby is very sick and it needs 100% oxygen. When you reach the point that you have to do the chest compressions. Last but not the least is the drugs. Adrenaline epinephrine dose is the same, almost is 0.02 ml per kg. One is to 10,000. First dose as early as 4 to 5 minutes, and IV recommended. If let's say you get the intubation, then you can give the first dose and then repeat it whenever you get the IV or the Amplicovine. The NRP edition is eighth edition is suggesting about the flush. When you give the first dose of IV or IO, then you flush the medicine with 3 ml normal saline as compared to the zero point 0.5 to 1 ml in the previous recommendation. And the reason is for that is I will show you now. This is the study which is published very recently last year in 2021 from the California. So let's see. So if you flush your medicine by 1 ml, the return of the spontaneous circulation after first dose is only 43%. And the median time to reach that is about 60 to 120 seconds. If you do with the 2.5 ml, the return of spontaneous circulation is about 80% after the first dose. And the median time is 56 to 111 seconds. But let's say if you are giving the 3 ml, the return of spontaneous circulation is almost 90%, and the median time is only 39 seconds. So that's why we have to flush it very quickly in 3 ml per kg. So let's say the baby is 3 kgs, then you just put the flesh the baby by that. Now, the neonatal resuscitation after the drug UV is the volume expansion. So let's say you know that there is a bleeding abruption placenta previa or trauma, then we have to give normal saline. The normal saline is the main, the recommended fluid. It's a 10 ml per kg and can be repeated, and should be over 5 to 10 minutes. Do not push the volume expansion. So as you can see here, that their class of recommendation is also very high. If you can arrange the negative blood and O negative blood, and you know there is a blood loss, let's say abruptio, or let's say the mother come after some trauma or accident, and you know there is a blood loss and you can arrange O negative, then of course it is better. Post-resuscitation care is the same. You have to take care of respiratory, cardiovascular, endocrine, and everything what you are doing now. You continue with the oxygenation, you maintain the blood pressures, you maintain the, you put the feeding tube, and so on and so forth. The only thing is which are available in some places, I think in Pakistan is in Karachi is only Khan have a therapeutic hypothermia facilities that they can do it. But anyway, it is a new thing for the Pakistan. It take a lot of effort. We are trying whenever we come to Pakistan, we are trying to develop it and see how we can do it. But for the other things, post-resuscitation care is the same. So the early kangaroo mother care for low birth infants are also very important, where the facilities are not there. If you can maintain according to this chart, it serves the purposes. It benefits both mother and the baby. So the early kangaroo mother care for low birth infants is recommended. Now, there is a table. This is the article written by the Dr. Ola Segerstad from Norway, and it shows if you are working in low resources condition, or if you are working in high resources condition, there's some differences. But what I recommended, that we have everything except one or two things which I mentioned, like blender and this thing which we can modify. Do accordingly, do according to the this algorithm, go step by step. Do not jump to the next step without doing the previous step properly. You can be better off, okay? And the babies can. You don't require very high-fi equipment. You just continue. You have to develop your skill how to give the positive pressure ventilation, how you can intubate the baby, or if you can have a laryngeal mask, then of course you can do it. Then epinephrine, I think, is available everywhere. Told you how much flush you can put it. Normal saline is available. How much boluses you can give it, but do it accordingly. Then I think we are doing the same as in the high resources countries. When to stop, it is very important. Now it increased to from 10 to 20 minutes, and the reason is that after that this mortality is very high and the intact survivors are zero. So all the babies after 20 minutes of good resuscitation, if you continue with that, the chances of mortality is very high. Why they changed from 10 to 20 minutes? Because they said that in this study, the survivor without moderate or severe NDI is 60%, and survivor without moderate or severe NDI is 7%. So they think that 20 minutes is more appropriate, but after that, the chances of survivor without any neurodevelopment impairment is very, very low. So you should continue up to 20 minutes and not more than that. But sometime what happened, because you are doing the chest compression, because you are giving in 20 minutes at least 4 or 5 doses of epinephrine, then there is some heart rate. So the after 20 minutes of good resuscitation, if you don't have the heart rate reach 60 and above, let's say is hovering around 20, 30, 40, you should bring the baby to NICU and just give the palliative care, because after that the chances of having neurodevelopment impairment is very, very high, and it is no point to continue for 40 or 50 minutes and to give the baby with the brain damage. Uh, this is another skills we have to develop. Our behavior, we should anticipate and plan, communicate effectively with the parents, use available information, use available resources, maintain professional behavior, know your environment. Do not use too many medical terms when you are talking to the parent. Just tell them very in a very simple language that what you are going to do with the baby, how the baby go through this process of delivery and the process of transition from in utero life to ex utero life. We have to be very professional. And believe me, if you do communicate effectively, they will really appreciate your effort. So please do not be in a hurry. Just give your time, explain the parents to that what is happening with the baby. So my conclusion, DR management must be steadily evaluated. We have to evaluate, we have to do the mock course, we have to evaluate our efforts, investigate it, and train to improve the resuscitation. Current neonatal resuscitation guidelines are focused and well elaborated. So please do one system. We have a lot of debates that which system we are using. Please stick to one system, which is the neonatal resuscitation NRP program. A strong effort must be undertaken to perform a study of high quality in the DR to further improve neonatal resuscitation and outcome of one of the sickest group of the newborn. So what do you mean? What is the meaning of that? In that conclusion, that we should continue to improve ourselves. Okay, so there's a strong and serious effort you should take to maintain what you are doing. So it is just the time, the development of the skills, and your enthusiasm and your professionalism, which can help the baby to bring out from this disastrous situation. So please maintain all these things. There's no need for hi-fi equipment, ventilation, and this thing. If you do these steps in a correct way, you can be better off. So Again, stabilization or resuscitation. So this is the Angela Krebs from Germany. She is the very famous neonatologist. She said that most premature babies and the full-term baby do not need resuscitation, they need stabilization. They need assistance in transition and adaptation. The physician is an observer and supporter of the infant own competencies. So please do not jump and giving too much oxygen, chest compression, or all these things. Do stepwise what we just discussed. With that, I will stop my talk and thank you very much for listening for that. If I do a little bit over, sorry about that, but these are all very important points we should have to discuss. And inshallah, I will be available for the Q&A session. Thanks a lot.
Thank you so much, sir. And definitely the importance of neutral resuscitation cannot be overemphasized. To remind again, the attendees can ask question in Q&A session, and the speakers will answer the question at the end of sessions. So moving on, our next speaker is Professor Talal Waqar. Dr. Talal is a consultant neonatologist and professor of pediatrics at CMH Lahore. He holds fellowship degrees in both pediatric and neonatal pediatric medicine. He is an examiner of and supervisor of FCPS neonatology program by CPSP. He has vast experience and has many research publications to his name. Dr. Talal will talk about right time and right choice of surfactant for treatment of RDS in neonates. Over to Dr. Lal.
Hello,
Audible?
can you hear me loud and clear?
Ji sir, you're audible, loud and clear.
Acha, and you can now see my slides also for us.
No sir, yes sir, your screen is visible now.
अभी
Slide
आपको
screen.
नजर आ रही है स्लाइड
जी सर,
पूरी
अब
नजर
नजर
आ
आ
रही
रही
है
है. जी.
Okay, and in there in the slideshow.
जी sir, full screen है.
Thank you.
Thank
Okay,
you.
thank you very much. Ji. Greetings from a cold and murky morning from Lahore. I'm extremely grateful to the team of Indus Hospital, Professor Rehan and his team for inviting me to this August conference and gathering. I wish we would have been around physically, but unfortunately, with COVID around and rising numbers, we couldn't do it. Taking it on further from Professor Junaid Mohib, who's adequately pointed out things that we are supposed to do in the delivery room. I'll take you to the respiratory management and particularly of surfactant therapy in next 20 to 30 minutes. We'll start with a case presentation out here. Uh, we'll start off from here. Asma, who conceives 7 years after post-marriage, has suddenly had a PV bleeding at 31 weeks. She is rushed to her nearest Tehsil headquarter hospital where Ali is born. He's 1700 grammar. He needs a bit of bagging, to which he responded well. He's shifted to NICU, where at 3 hours he develops respiratory distress. The distress worsens in next 12 hours. They plan to shift him to a nearest district hospital and a tertiary care hospital, where the registrar on duty gives him a prescription which has 2 vials of surfactant and a bit of other equipment which he needs to buy. To his surprise, when he lands in the pharmacy, he is handed a bill of around 40,000. At that point in time, this poor chap doesn't have anything. He plans to sell off his motorbike, which is his only resource, and he buys this vial which has surfactant in it. So the objectives for next 20 to 30 minutes would be to look at the history and composition of this injection that Asma's husband had to trade in for his saving. What are the benefits of this? How soon it needs to be given? Should THQ have given it? What are the best methods to give it? And what are indications other than respiratory distress syndrome? Was it really worth it that he had to sell off all things, and were there any alternatives available? We look these points in next 20 minutes to 30 minutes time. Okay, the care of preterm baby has always remained a challenge, and Pakistan is no exception to it. We are rather in the very top global burden of prematurity. We are probably second or third, or maybe fourth, probably second or third when it comes to the birth of preterm deliveries in our part in Pakistan. So, taking things right from the history, even before Premi started surviving, we knew that the major cause of mortality was respiratory compromise, a disease by the name of RDS, which we now know, was even recognized earlier on also, but the people did not know the nitty gritty of the disease itself and the pathophysiology. A German obstetrician first time described this disease with a phrase fetal lung in a baby who's born. I think there's no better phrase than this. It has never been replaced by a better phrase. It was thought that hyaline membrane was found in this disease, and it was thought that it was secondary to aspirated vernix. By 1946, they had actually discovered a substance which was dipalmitoyl lecithin, but they did not know that what was its use and was it used in the surface active properties of the alveolar wall. So it was up to Mary Ellen Avery in 1959 when she came up and connected the dots together, and she found out that hyaline membrane disease was actually associated with the lack of this lecithin material, which we now call surfactant. And this surfactant reduces surface tension in a normal baby from 8 dynes to 30 dynes. Sorry, it's the other way around. It reduces surface tension from 30 dynes to 8 dynes in a normal baby. A baby who's got hyaline membrane disease has a surface tension far greater than a normal baby. So it was this lady which came up and discovered this material itself. Nobody paid any hoots to this lady till, as luck would have it, bad for Kennedys but good for neonatology. Neonatology had a jump start, and people recognizing this disease and paid attention to what Mary Ellen Avery said when in 1963 John F. Kennedy's son was delivered who suffered RDS. We all know this thing very well that neonatology, Kennedy has a role to play, though in an unfortunate one, but he did have a role to play in the uplift of neonatology. After Avery's evidence, it was time to put two and two together and start doing animal studies. Initially, rabbits were enrolled for animal studies, and then later on, premature lambs were included. And all these studies reflected and concluded that tracheal installation of natural surfactant to a premature lamb protects lungs from developing features of respiratory distress syndrome. Naturally, as we would now have it, after animal studies, it was time to impart what had been learned to our newborns. And it was Japan and it was Fujiwara in Japan who did the first trial, and he had 10 babies, out of which 8 survived. They instilled surfactant and looked at partial pressure of oxygen. And they found out that the partial pressure of oxygen rapidly improved in all babies, on preterm babies. And out of them, at least 6 of the babies were less than 1500 grammars. And the partial pressure of oxygen adequately rose very well. Now that we had this trial in 1980, it was time to do a proper randomized control studies. And the first randomized control trial was published in 1988 in Pediatrics, which involved 146 babies. It was a randomized control trial with installation of Curacef and control babies who did not have it. And the results were that surfactant decreased neonatal mortality by 20%. It not only decreased mortality from RDS, but also decrease the incidence of emphysema as well as pneumothorax significantly. So after this randomized control trial, there is a flurry of evidence generated all along the world with lots of papers coming out from all parts of the world and different countries, which then started doing trials on surfactants. Now that we had sufficient evidence, it was time to knit things together and to analyze this evidence. And our good old Cochrane came to help. In first meta-analysis was published in 1997, and they found out that prophylactic animal-derived surfactant reduces risk of RDS and neonatal mortality, not reduces the risk, but reduces neonatal mortality by 40%. It also decreases the incidence of pneumothorax by around 60%, with a typical relative risk of 0.4, which means that 60% reduction in the incidence of pneumothorax, and incidence of pulmonary interstitial emphysema was also reduced by around 55%. So these were groundbreaking research analysis. And after that, they also noticed that in the similar meta-analysis, did they have any effect on other things? Installation of surfactant to babies did not have any effect on PDA. It did not have any effect on intraventricular hemorrhage. NEC, no effect. And similarly, there was no effect on neonatal sepsis when surfactant was instilled in babies having RDS. Now let's shift gears a little bit and I'll tell you physiology, but I won't bore you much with it. We'll only have 1 or 2 slides for it. What is this magic substance that we are talking about today? It contains a huge amount of lipid in it with a very small amount of proteins. It reduces surface tension. And what happens is that according to the Laplace law, the force, the pressure that is required to open the alveoli is twice the amount of surface tension. So the greater the surface tension, the greater the force that is needed to open the alveoli, and the smaller alveoli then collapse into the larger alveoli. So we need a surface active material which needs to reduce the surface tension. And this lipid material, which contains 97% lipid and only 93% lipid and only 5 to 6% of proteins, acts and reduces the surface tension, helps in opening up the alveolar area. It also has other benefits and it has a dual role also, but this is a minor role just to mention. It also reduces the incidence of infections, and it has been noticed that it helps in the phagocytosis, it helps the macrophages, it has some role in reduction of pneumonic illness, as well as a bit of innate immunity generation. Okay, so what can go wrong in cases where surfactant, what can go wrong with surfactant? We can either have too little surfactant from decreased production in alveolar type 2 cells, that is in prematurity, or we can have enough surfactant, but the surfactant gets destroyed very easily. Now we look into surfactant replacement therapy, because if we have these two things that I've just mentioned it, we need to replace surfactant. And we look into the evolution of it, the prophylactic versus rescue use, its delayed or early use, whether we should use animal surfactant, whether we should use, if we use animal surfactant, which surfactant is better, the porcine one or the bovine one. So over last couple of years, during the first guidelines were published in 2007, every year the European Society updates these guidelines for respiratory distress syndrome, management of respiratory distress syndrome. And the last guidelines that were updated were in 2019. The first guideline that was published in 2007 gave a definition of respiratory distress syndrome, which was very different from the definition that we have today. The Vermont Oxford Network defined RDS as babies with respiratory distress who have a partial pressure of oxygen less than 50 millimeters of mercury in room air. They need supplemental oxygen, they are cyanosed, and they have classic chest x-rays. This was the definition that was given in 2007 and later endorsed in 2010. However, what do we have now? In 2019, we now, according to the European consensus guidelines, we need radiological appearance, ground glass, and air bronchograms. They are out because babies do not now, with the use of antenatal steroids, we are not seeing that amount of RDS. But in Pakistan, yes, we do see that amount of RDS. The definition is not based on blood gas analysis, but it's a pragmatic definition in where the work of breathing and inspired oxygen requirement is increased in babies with respiratory distress. So, as far as the international consensus guidelines are concerned, of 2019, radiological appearances of ground glass appearance with air bronchograms are rarely seen today. Definition based on blood gas analysis are also out, and clinicians have moved towards a pragmatic approach where clinical assessment of work of breathing and inspired oxygen requirement is defines RDS in very early course of disease. However, what do we have for Pakistan? Our very own Professor Khalid Haq, in his seminal paper, as well as in one of his books, which I have also co-authored, mentions that RDS is defined in babies who present within 4 hours of birth with respiratory distress, have an oxygen need, are less than 34 weeks preemies, must have an evidence of radiological features of RDS. So, as far as our population is concerned, we still think that Dr. Haq would bear me out with it that presence of X-ray changes are important. Okay, now how soon we need to treat it? If we think now that we've defined RDS, we can take European definition if you're working abroad, we can take Pakistani definition if you're working in this part of the world. Now, if we say that the baby has significant RDS, how soon do you need to treat it? Do we need to treat it right at delivery? Do we need to treat it after in the NICU, or we need to treat it later, anytime in first couple of days? So we look into the evidence, whatever we have till now. First of all, the prophylactic administration of RDS. Prophylactic is preventive RDS strategy where you actually want the baby not to develop RDS. The timelines that are defined for it are within first 10 minutes after stabilization, like Junaid Mohib has pointed out. After you have stabilized the baby, you decide that you need to give RDS. It's the prophylactic RDS is anytime between 10 minutes to 30 minutes of age. But now, what was the evidence of prophylactic RDS and is it still used or not? What does Cochrane say? In 2001, the Cochrane published a meta-analysis where early trials of prophylactic versus surfactant RDS was looked, and it was found that yes, prophylactic surfactant is helpful and is beneficial. But mind you, this was 2001, and I've written this is not the most recent version. Let's look at the most recent version. By 2012, we had larger trials. We had babies who were given antenatal steroids. CPAP was in vogue all along the world. And now, when they looked at the studies, they found that there is no benefit of prophylactic RDS when compared with CPAP. So, what do we take from this? Prior to 2013, we thought that prophylactic RDS is important. But after 2013, there is no role of prophylactic RDS. There is no role, I'm repeating, of prophylactic RDS. Prophylactic surfactant. There is no role of prophylactic surfactant. And this has also been endorsed by American Academy of Pediatrics. The Europeans also say that there is no role, and American Academy of Americans also support these findings. However, that's very important. If we decide that the baby needs intubation secondary to RDS right at the time of delivery or in the first 30 minutes of life, we are supposed to give surfactant. So now the prophylactic role is only and only if you need to intubate the baby, because moving away from prophylactic was because you need to prevent intubation. But whenever you have intubated the baby, then you can give prophylactic prophylactic surfactant. Okay, so now we've seen that there is no role apart from the fact that you have intubated the baby and you decide that you need to give surfactant. Otherwise, there is no role. Okay, now that we need to see when do we need to treat. As I've said, that the pragmatic latest guidelines of 2019 suggest that worsening RDS with FiO2 increasing, judgment of work of breathing is increasing, and oxygen requirement is increasing. They've kept a threshold of 30%. Why do we have a threshold of 30%? If the baby is requiring more than 30% oxygen, you need to give surfactant. Why do we have 30%? Because there are studies which say that the incidence of CPAP failure increases exponentially if the baby is needing more than 30% oxygen. So the European Society recommends in 2019 that if the oxygen requirement is increasing beyond 30%, your baby is on CPAP, you need to think about giving surfactant. Now that you've decided that you need to give surfactant and your oxygen requirement is increasing, how soon you should need to give. Cochrane meta-analysis suggests that the earlier you give, the better it is. Within first to 2 hours is much better than beyond 2 hours of life. I'll discuss this point, that this creates a subtle dilemma, which I'm going to discuss it in a few minutes. So we've come to this conclusion that earlier you give, the better it is. Prophylactic, no. Prophylactic, yes, only in cases where you need to intubate them. Otherwise, give them a trial of CPAP, put them on good pressures of CPAP, monitor the FiO2. If the FiO2 increases more than 30%, plan and go for surfactant. What are the different surfactant preparations available in the market? We have animal-derived surfactant, we have synthetic surfactant. Animal sources are pork and animal sources are cow. Synthetic ones are first generation, second generation, and third generation. First generation did not have any protein component in it. Second generation, they tried to add protein components but still failed. It wasn't very helpful. They're trying to develop analogs of proteins into the third generation, which is not yet available and is something to look at it later. But we are mainly concerned with animal-derived and surfactant, animal-derived and synthetic, and what are the benefits and which one should one use. Natural surfactant is obviously better. 2001 meta-analysis suggested that natural surfactant is better when compared with synthetic surfactant. This was further endorsed and reinforced in 2015, and comparative trials greatly suggest that animal surfactant is better than synthetic surfactant. It decreases the requirement for ventilatory support. There are fewer pneumothorax incidents and fewer deaths associated with animal surfactant. When we come to animal surfactant, we have two different preparations which are available. The first ones are cows, and the second is pork. I know people may disagree with me on this slide, but the meta-analysis suggests that there is not much difference between the two if you look at only the doses of comparative doses. But if you use 200 milligrams of porcine surfactant, it is better than 100 milligrams of cow-based surfactant. But when you compare them at the same doses, there is no difference between the two. You can, I can, we can differ on this, but that's what the take over world over is on this thing. Okay, what are the different surfactant methodologies? Previously in 2007, the methodology was that you need to intubate them, ventilate them, keep them there. But even in 2007, it was thought that ventilation is bad and you need to extubate them as soon as possible. Later, we came to this thing that you need to, even on a baby, you need to just give ensure technique. Ensure technique was intubation, surfactant, and extubation to CPAP. You intubate the baby, you give him surfactant, you extubate to CPAP is far better than putting on ventilation, because ventilation causes volutrauma, barotrauma, and has side effects. I've categorically put this slide for colleagues in Pakistan because many still use this technique of giving surfactant in different positions. There is no evidence, there is no need to shift the positions, there is no evidence for this technique as far as meta-analysis and research is concerned. Okay, can we actually avoid mechanical ventilation if it is all that bad? Yes, we can. According to the new, it's not new, it's about a decade has passed, that we can give surfactant to babies with LISA and MIST technique. And meta-analysis and lots of research studies which show that percentage of babies needing supplemental oxygen was less when LISA was done. Percentage of babies requiring ventilation, repeated ventilation, was far less when LISA technique was used. So least invasive surfactant in a spontaneously breathing babies by use of a nasogastric or a special LISA catheter is in vogue and is the latest thing which is available now. And meta-analysis supports these findings that when compared with endotracheal intubation, LISA is far better than endotracheal intubation because baby is spontaneously breathing. There is homogeneous distribution of surfactant within the alveoli, and this is something very latest which has come back in about a year ago. We have now robust evidence. Okay, a little bit more. What are the practical issues? Now, on one side, I have told you that surfactant only needs to be given. The recommendations are that prophylactic is out and it only needs to be given if the baby is failing on CPAP. On the other hand, we are also telling you that the earlier you give, the better it is. So this creates a dilemma. In order to answer this dilemma, people have come now to this thing that 30% oxygen FiO2 is good. Some have also come up to this thing that we can have a personalized management for surfactant. And in this personalized management, there is now a role of ultrasound guided surfactant management therapy, where you use ultrasound as a technique to identify significant respiratory distress. It has got a good ROC, it has got a good area under the curve with the sensitivity pooled specificity of something like 84%. And you use, it's a good technique. We can learn it. It's not a very difficult learning curve. And we can learn it and we can decide to give surfactant based on this technique. All I'm trying to say is that yes, we need to give early, but we just need to be sure that the baby has got significant RDS in order for it to have received surfactant. What are the other conditions where surfactant may be useful? People have seen that surfactant may be useful in similar pathologies where there is decreased lung compliance, has increased resistance, and baby has respiratory failure. Other indications are meconium aspiration, pulmonary hemorrhage, and severe pneumonia. However, when we look at the meta-analysis, all the studies which have been done in these pathologies are heterogeneous, they are non-uniform, and hence all I'm saying is that we need, yes, surfactant is useful in meconium aspiration where there is surfactant consumption and destruction, but as far as evidence is concerned, we still lack very robust evidence. It should be generated. Last two slides. What is it for knitting together for Pakistan? We are a developing world. Surfactant is expensive. with a higher incidence of RDS, with an incidence of anything between 40 to 65%. Is it feasible to give surfactant right, left, and center in Pakistan? Probably yes or no, but probably no. Yes, we need to give surfactant, but all I'm saying is that first we need to make sure that we have enough antenatal steroid coverage in the population. We have delivery room stabilization, which Dr. Junaid has pointed out. We have good NICU care. We have adequate CPAP in our setups. We have capacity for babies to be taken care of. And then, yes, surfactant is a very good therapy, no doubt. What does the future hold for surfactant? WHO has now come up with this thing that we need to plan trials for aerosolized surfactant in developing world, because intubation is difficult in our part of the world. Ventilation is a hard task. It is difficult. It has got lots of complications. We don't have one-to-one nursing cares, and in low and middle income countries, I think the way forward would be aerosolized surfactant. We have recently attended a meeting. I know AKU people were involved in it, and in 2022 and 23, they are planning some trials in low and middle income countries where aerosolized surfactant would be the future. So, in summary, what we've learned in last 20 to 30 minutes: surfactant reduces surface tension. It has some anti-infective role. It reduces mortality in RDS. It decreases the incidence of pneumothorax. There is no prophylactic role except when intubation is needed. It needs to be given as soon as possible. However, in places where you have the infrastructure, least invasive surfactant is now the way forward. In other conditions, yes, probably yes. In meconium aspiration, we can use surfactant. Is it really worth it? Yes, it is really worth it, but in places where you have adequate support. I know there are places which do not have CPAPs in Pakistan. There are places which do not have care of newborn babies. They have rudimentary neonatal setups, but they plan to give surfactant. They hand over this prescription to parents and tell them to go and get surfactant. So I think that's probably that needs to be changed. Thank you very much. I'll be available for any question answers. I'm live here and I'm sitting here. Thank you, Vikram. Thank you.
Thank you so much, sir. It was indeed a very informative talk. To remind again, the participants can ask question in Q&A session, and the speakers will answer the questions at the end of the session. Before we begin our next session, uh, let me ask you a question just to check if you are awake, and actually it's Sunday, and just to see all are attentive or not. So please hear my questions very carefully and give your answers in the chat box, and I will answer to my question after the next presentation. Please listen to me carefully. It's just an icebreaker. I am a fruit. I am tasty and provides lots of energy. You can also find me in a calendar. Who am I? I'm repeating my question. I am a fruit. I am tasty and provide lots of energy. You can also find me in a calendar. Who am I? Participants can answer in the chat box. I'll give the correct answer after this presentation. Our next speaker is Professor Dr. Khwaja Irfan Waheed. He is a professor of neonatology at the Children's Hospital and University of Child Health Sciences, Lahore. He is a graduate of King Edward Medical College and holds fellowship degrees in both pediatrics and neonatal medicine. He is a supervisor and examiner of CPSP for FCPS neonatology. He is a founder, member, and director of many specialized neonatology courses, including neonatal life support, helping babies breathe, and helping babies survive courses. He is a reviewer of many research journals and has authored 4 books. Professor Irfan will enlighten us today on high flow oxygen therapy in neonates. Over to you, sir. Dr. Irfan.
Am I doing it live? Ladies and gentlemen, Assalamu alaikum. First of all, I am very grateful to the organizers of this conference for inviting me to talk on this very important subject, which is nasal high flow therapy in newborns. My talk will compose of a little bit of introduction about nasal high flow therapy, its mechanism of action, benefits, its indications, contraindications, how to set up a nasal high flow therapy circuit, how to wean, and what are the complications related to nasal high flow therapy. First of all, let me explain about some of the common synonymous terms which are used for nasal high flow therapy. The common one is nasal high flow therapy in neonates. Another one which is used is nasal high flow oxygen. This is not primarily used in neonates, but it is generally used for adults because oxygen as a pure form of oxygen is not used in newborns in high flow therapy circuits. Therefore, another term came into existence, which is nasal high flow oxygen oblique air, which is a combination of oxygen and air to a certain mixed value. But the proper term for this mode of ventilation is heated, humidified, high flow nasal cannula in neonates. So this is a proper word which is used and generally abbreviated as nasal high flow therapy in neonates, not as nasal high flow oxygen. So what is nasal high flow therapy? Nasal high flow therapy refers to the delivery of humidified, heated, and blended oxygen or air at flow rates greater than 1 liter per minute via nasal cannula. And nasal high flow therapy started initially in the year 2000 as an alternative to respiratory support to nasal CPAP that was and those times used for only in preterm infants. The principle that is used by nasal high flow therapy is based on Paisal's law, which states that pressure is directly proportional to flow for liquid or air that flows through a tube. Higher the flow, higher the pressure, provided the resistance is kept constant. As a result of higher flow, it delivers a positive distending pressure at higher gas flow rates, and that is the basis of use of nasal high flow therapy. So mechanism of action of nasal high flow therapy comprises about 4 different types. One is that it flushes the dead space, and flushing of dead space in nasopharyngeal cavity is an important and novel concept to reduce dead space that makes minute ventilation more efficient. It supports inspiration. How? The adequate gas flow that exceeds physiological inspiratory flow, it reduces inspiratory resistance in the nasopharynx and thus reduces work of breathing. The gas conditioning is done through a humidifier, and the heated and humidified air, it improves pulmonary mechanics, mucociliary function, and it prevents airway water loss and cooling. Another very important aspect of the mechanism is delivery of a positive distending pressure that reduces inspiratory work of breathing and provides some degree of PEEP or positive airway pressure or CPAP, whatever you want to call it. Technically, CPAP is given through nose, and PEEP, the word of PEEP, positive end expiratory pressure, is used for positive pressure given through an endotracheal tube. But generally, both of these terms are used interchangeably. So in which patients is nasal high flow therapy indicated? Initially, it was used in an alternative to nasal CPAP support. And when it was weaned from, baby was weaned from nasal CPAP, it was then put on nasal high flow therapy, and it was found to be effective. The basis is that the nasal CPAP you use generally more than at 5 centimeters of pressure, where the highest permissible flow in newborns through nasal high flow therapy, it also generates a pressure of roughly about 4 centimeters of water. Therefore, while weaning from a nasal CPAP, when one reaches 5 centimeters of water pressure, it can very safely be switched to nasal high flow therapy at a higher level, at which it can deliver 4 centimeters, a perfectly reasonable system for weaning from CPAP. It was also indicated in relief for those babies who have already sustained iatrogenic nasal skin trauma from nasal CPAP. Nasal CPAP uses a nasal breathing uh, interface that, if uh, put on for a long time, and because it is put against the nasal septum with the pressure, it can cause nasal trauma. While this problem can be very easily bypassed through nasal high flow therapy. It was also used, and still many of the researchers, they believe that it should be used as a post-extubation in a non-invasive respiratory form of non-invasive respiratory support. That is, that once you have extubated a baby from CPAP, it can be put on nasal high flow therapy straight away. But research has also shown that the failure rate in case of those babies who are directly put on nasal high flow is higher as compared to those babies who are put from CMV to CPAP. Nasal high flow therapy was also used in post-operative respiratory support and in prevention of apnea of prematurity. Apnea of prematurity, though it is central, but there is also a peripheral element. So it is known as a mixed apnea, and nasal high flow can very easily use in the treatment of apnea of prematurity. In those babies who have chronic lung disease, in which CPAP has been used for a fairly long time and has come to lower pressure, nasal high flow therapy is very convenient in those babies and is used in routine. So what are the benefits of nasal high flow therapy over other forms of non-invasive? First, the best one is that it causes less nasal trauma because the prongs are not placed snugly to the nasal septum. So very easily it can be placed and it doesn't disturb the baby's nasal septum, as is common in CPAP or BiPAP. Baby is very well settled and comfortable. There is parental satisfaction for the reason that even a baby with nasal cannula can be very easily held by the mother in the lap and can feed from the breast. There is less gaseous abdominal distension as compared to other forms of non-invasive ventilation, and they therefore very easily nursed by the mother in her lap. It gives a better access for the procedures. Baby can very easily be placed on a flat surface and the procedures required can be done. In CPAP, there is during weaning, there is a period of time off, but during nasal high flow therapy, you don't need any time off. It is gradually weaned off to zero. And therefore, because of better feeding, the baby has improved growth. Then in certain babies, it cannot be used. And which are those babies? The need for intubation and or mechanical ventilation, whenever it exists, of course, you cannot use nasal high flow therapy. Nasal high flow therapy can only be used in self-breathing baby. If the baby is having frequent apnea and he has unstable respiratory drive, of course, then again nasal high flow therapy cannot be used. If the baby is not self-breathing, nasal high flow therapy cannot be used. If there are upper airway abnormalities, for example, cleft palate or cleft lip or tracheoesophageal fistula, nasal high flow therapy is not effective. Or if there are neuromuscular disorders in a newborn, which lead to severe neurological impairment, then of course, again, nasal high flow therapy is contraindicated in such babies because it cannot produce the desired effect. There are only two things in the two parameters in blood gases that can be controlled through ventilation, whether it be invasive or non-invasive. One is carbon dioxide and other is oxygen. Because nasal high flow therapy is also a form of ventilation, so we can only control two things. There are two available controls. One is flow, you can control only flow, and the other one is fraction of oxygen in the inspired air. There is no other control in high flow therapy. So how to use these two for controlling carbon dioxide? That is, of course, flow. Increased flow will, of course, increase the PEEP or CPAP or the pressure or the distending pressure, whatever you want to call it. And increased distending pressure, of course, will increase the minute volume, which will reduce carbon dioxide. For control of oxygen, both flow and oxygen, if you increase fraction of oxygen in inspired air, of course, oxygen is going to go up. And similarly, increased flow will cause increase in pressure, which will distend the alveoli further. More surface area will be available, and therefore oxygen will improve. So this is a crucial slide. If you need to control carbon dioxide, you have to need to control the flow, and if you need to adjust oxygen, you can use both the controls. This is the circuit diagram. There is an air source and there is an oxygen source. Both of them, they are connected to an air oxygen blender. Air oxygen blender can give you a desired oxygen concentration according to the baby's saturation. This air then passes through a humidifier, and then this humidifier is connected through a heating circuit to nasal prongs, which must be loose in the nares. Air oxygen blenders are easily available and can be very helpful in controlling the amount of oxygen that needs to be given. There is another point that must be noted, that any flow of air more than 1 liter that is given to a baby must be humidified. Some books have also written 2 liters, and because high flow therapy conventionally is more than 2 liters, the air must be humidified before it's delivered to the nares of the baby. And now, how to set up a nasal high flow therapy unit? You need a blender. Blender is connected through a circuit to a humidifier, and then this is a humidifier heating base, and this is the nasal prongs. All of them are connected in the form in series, and this blended air and oxygen and humidified is delivered to the baby through a simple nasal prongs. This is a indigenously developed circuit which can give both. This is a machine, a piece of equipment that can give both high flow therapy as well as CPAP just by change in circuit. Basic machine stays the same. What are the practical considerations for use of nasal high flow therapy? First of all, the choice of cannula is very important. The cannula that is put in the nose must not obstruct more than 50% of the diameter of the nares. There must be an open space. Otherwise, whatever the air if it is tight fit in the nose, whatever the flow you are giving to a baby will directly cause pressure, and it can be harmful and cause pneumothorax. So the cannula must not obstruct more than 50% of the diameter of nares. All the babies on nasal high flow therapy should be nursed with an OG tube. They should not be put nasogastric tube, because NG tube also occupies some of the space in nares, and moreover, the secretions that accumulate on the NG tube, they will reduce the space in the nares. The temperature should be set at 37 degrees centigrade for all the starting flow rates. The flow rate that is used in newborns, the range is between 1 to 8 liters per minute. For all those babies who are more than 1 kilogram, the maximum flow rate is 8 liters per minute. And for those babies who are less than 1 kilogram, the maximum flow rate is 6 liters per minute. And this is an algorithm how to start and how to move up and down. So in a baby on which nasal high flow therapy is indicated, start nasal high flow therapy at 4 liters per minute at an oxygen concentration which is a little bit higher than the previously given oxygen, generally between 30 to 60%. Never go up 60% of FiO2. So there are two possibilities. Either the baby will maintain SpO2, or and then if the baby maintain SpO2, we can continue and follow the weaning protocol. But if the baby is not maintaining saturation, then review the baby every 15 minutes and increase the flow if required by 1 liter per minute. Please do not leave the baby after putting on nasal high flow. It's a very dynamic process. You need to review the baby frequently in order to make adjustments. So review the baby every 15 minutes. And if the baby is not maintaining SpO2, you can first go up on FiO2 to 60%, maximum 60%. Some of the books, they mention 40%. But we go maximum up to 60% because above 60%, it becomes harmful to the baby. And if still it is not controlled FiO2, then we can go up on the flow rate. And we increase the flow rate by 1 liter per minute to a maximum of 8 liters per minute in babies who are more than 1 kilogram, and to a maximum of 6 liters per minute in those babies who are less than 1 kilogram a baby. So after making such adjustment, if the baby starts maintaining SpO2, we will move on to the weaning protocol. But in case if the baby is not maintaining SpO2 and the PCO2 starts rising, then it means that as nasal high flow therapy has failed, and we need to consider other modes of assisted ventilation. So once the baby is stable, we now know how to start and what are the indications and how to start the baby on nasal high flow. So once the baby is stable, how to wean it? That's more tricky. The purpose of weaning is to provide minimum level of support required. So you gradually reduce the support and see whether the baby can maintain himself or herself. So when do we start? Once the baby is stable, maintaining SpO2, there are absent signs of respiratory distress and the acceptable blood gases, we will start weaning. And how to wean then? Set a target SpO2. That SpO2 of all those babies who are being ventilated or given respiratory support is between 90 and 95%. Then if SpO2 is above the target, it means that it remains above 95 for some time, for 5, 10, 15 minutes. Reduce the FiO2 by 5s to 30%. That is, if initially the baby is, let's say, on 40% and is maintaining SpO2 above 95%, then we can reduce the FiO2 by 5 to reduce it. We will reduce it to 35. In next 15 minutes, again, if it is maintaining above 95%, we can go on down to 30. So we reduce the FiO2 by 5s. Then first we reduce FiO2 up till less than 30%. And then after, if it is more than 30% FiO2, we cannot reduce the flow. But once it achieves 30%, then the next step, or if it is between 25 and 30%, we can then start reducing the flow by 0.5 to 1 liters per minute every 24 hours. Of course, it depends upon the baby's condition. If you feel that a baby is stable enough, then it can be made a little earlier, not waiting for 24 hours. When the FiO2 reaches less than 25%, then the flow is reduced by 0.5 liters per minute 12 hourly till the flow reaches 12 liters per minute. And then nasal high flow therapy can be discontinued. And if only SpO2 is below the target, we will need only low flow oxygen. When we call, for example, if we are weaning a baby and there is significant and sustained increase in respiratory rate or work of breathing or oxygen requirement, it means, this happens within 24 hours of weaning, it means that the weaning has not been successful. We need to resume nasal high flow therapy. How to monitor a baby during nasal high flow therapy? Blood gases and X-ray chest are our eyes and ears to control nasal high flow therapy. Please do the blood gases. Specifically, we need carbon dioxide and oxygen level, which will ultimately affect pH and bicarb. But primary controls are through carbon dioxide and oxygen. So this, according to the blood gases, we need to adjust further settings. Either we have to go up on FiO2 or below Either we need to adjust the flow, all will be shown by blood gases. X-ray chest, the most important point to see in X-ray chest is either the condition of the lungs or the level of the diaphragm. Regular assessments of vital signs are also very important, and we also need to see the trend of giving the fraction of inspired oxygen and the SpO2 of the baby. Please note that whenever you're taking a blood test, the baby must not be handled at that time. Leave the baby for a while, 10-15 minutes, and then take the blood sample. If you are examining a baby at the same time when the blood test is done, the blood test is likely to be wrong at that time. Nursing care, of course, is extremely important. Care of nose is of primary importance. Please do not let the nose be blocked by the secretion. It has to be monitored periodically. The environment should be clean. There should be no noise, minimal handling, unnecessary light should not be there. Humidification is an absolute must. The monitoring of vital signs. The baby should be kept in prone position unless the baby has central catheters in and umbilicus. Care in bowel of bladder and the feeding must not be stopped. It should be continued as per routine. Infection control practices are a must in all types of respiratory support. In nasal high flow therapy, the nasal prong circuit needs to be changed every week. And if you're using a disposable flow circuit, it should be changed monthly if a prolonged need for high flow therapy is there. The nasal high flow therapy unit itself, that it means the humidifier and the blender, should be disinfected according to the manufacturer's instructions. There are some complications that are associated with the nasal high flow therapy. If the nasal prongs are tight in the nares, it will cause excessive positive airway pressure, which can lead to pneumothorax. It's an absolute must that the nasal prongs inside the nares must not be tight, and they should not cover more than 50% of the nares. It can cause trauma to the nose and the skin if the prongs are long and or if they are held tightly against the septum. There is increased risk of apnea with rain out, and rain out means that all the humidification in the circuit and that the water goes into the baby's nose. Rain out only occurs if you are not using a humidified circuit. So it is always safe to use the heated circuit. Occlusion of the nasal cannula can occur. We must be vigilant. Nasal secretions can block the nasal cannula and therefore can lead to hypoxia and erroneous FiO2 requirements. Abdominal distension can occur in all forms of non-invasive ventilation, as in nasal high flow therapy, because of the air is being given through the nose and it can go into the stomach. It is better to keep an OG tube in place and keep it open. The end should be kept open so that all the air that is being collected in the stomach should flow out through the OG tube. So in summary, nasal high flow therapy is a very cost-effective mode of non-invasive ventilation, and currently in all the world, the nasal high flow therapy as well as other modes of non-invasive ventilation are taking precedence over invasive ventilation. First line of non-invasive ventilation is in self-breathing babies. This is the first step of ventilation, where if you have to put a new baby on requiring respiratory support, this is the first step. If it fails, then we can go on to the CPAP. Effective and timely nasal high flow therapy reduces the need for invasive ventilation. This is more acceptable for babies and families. And while doing a nasal high flow therapy, if we need to step up, increase FiO2 first, followed by flow rate. So you, whatever the protocol of your department is, first reach the FiO2, highest FiO2. We give maximum of 60%. Some books have mentioned 40%. And after you have reached this, then you increase the flow rate, as I mentioned earlier, how to go up. So while coming down, while weaning, first reduce the FiO2, followed by the flow rate. And then gradual weaning reduces the chance of nasal high flow therapy failure. Thank you very much for your patient listening.
Thank you so much, Dr. Irfan. It was indeed a very informative talk. High flow nasal cannula therapy is the type of modality which we commonly use in our setup, and it is very effective. And it would be great if other centers also start using this modality because it is very effective. I'm very much delighted to have very experienced senior colleagues who have joined us: Dr. Khalid Haq, Dr. Naveed Durrani, Dr. Sikandar Hayat, Dr. Bashir Abro, Dr. Asad Maqbool, Dr. Mahmood, Dr. Sadia Yasmin. Thank you all for joining us. And before we move on to our next session, I had asked you a question before this session. It was an icebreaker. My question was I am a fruit, I am tasty, and provide lots of energy. You can also find me in a calendar. Who am I? Many of you have answered it correctly. And thank you so much for your attention. आप लोग जाग रहे हैं, खुशी हुई बहुत देख के. The correct answer is dates. Thank you so much. Moving on to our last session, our speaker is Dr. Yasir Masood. Dr. Yasir is working as consultant pediatrician and neonatologist at Shifa International Hospital, Islamabad. He is a graduate of King Edward Medical University, Lahore. He did his fellowship in pediatric medicine in Pakistan and later completed highly competitive specialist training in pediatrics and neonatology from UK. He has worked at many renowned teaching hospitals in UK. He has many research publications to his name. His special areas of interest are premature and low birth weight babies. He will talk on caffeine beyond apnea treatment. Dr. Yasir.
Assalamu alaikum. My name is Dr. Yasir Masood, consultant neonatologist from Shifa International Hospital, Islamabad. And I'm very grateful to my colleagues at Indus Hospital and the organizers of ICON 2022 to give me the opportunity to come and talk about a very important aspect of neonatal care. I'm going to discuss about caffeine and how we can use it for different aspects of neonatal care and not just for apnea of prematurity. Probably one of the commonly used medicines in neonatology, especially in the last 10 to 15 years, the use of caffeine has increased quite significantly. And one of the reasons is that we as neonatologists have been trying our best to use more and more non-invasive ventilation for our preterm babies so that we can keep them off the ventilator and reduce the incidence of chronic lung disease, reduce the incidence of bronchopulmonary dysplasia, and avoid all the complications related to mechanical ventilation. And probably that's one of the reasons that the use of caffeine has increased a lot. This is one of the studies from 2016, which shows that over the period of sort of last 15 years, from 2000 to 2014, you can see a very steady increase in the use of caffeine. And obviously from 2014, we are now in 2022. I'm sure this percentage has increased quite significantly now as we speak in 2022. I'm going to spend a few minutes talking about CAP trial. Probably everyone who works in neonatology is aware of this very interesting trial, caffeine therapy for apnea of prematurity. And this is one of the very well-conducted randomized control trials which showed the short-term and long-term benefits of caffeine therapy in preterm newborns. The primary question the authors of CAP trial they wanted to ask was that whether caffeine use is safe in preterm babies or not. It's interesting that they were not looking whether caffeine reduces apnea of prematurity or not, because I think that probably was already known. Their primary focus was whether the use of caffeine is safe in preterm babies or not. So what they did was that they randomly assigned 2006 neonates to either receive caffeine or placebo. So it's quite a decent number, 2006 neonates. And their primary outcome was composite of death, cerebral palsy, cognitive delay, deafness or blindness at a corrected age of 18 to 21 months. This was their primary outcome. And what they saw in terms of the short-term outcomes, that in all those babies who were in the caffeine group, the positive pressure, positive airway pressure, either through the endotracheal tube or through the CPAP or oxygen therapy, each of them were discontinued at least 1 week earlier for infants who were in the caffeine group than in the placebo group. Significant p-value. This is quite quite an impressive and quite important short-term benefit of caffeine for preterm babies. Then these are the outcomes they looked at before discharge home in all those 2006 infants. A very interesting table, and if you just looked at what they found was that bronchopulmonary dysplasia was statistically significant lower in the caffeine group. As you can see, 350 units in the caffeine group and 447 in the placebo group, and p-value is significant, and also the odds ratio as well. What they also saw, incidentally, that the drug, the medical and the surgical treatment of PDA was also statistically significantly lower in the caffeine group as compared to the placebo group. So these were the three important short-term outcomes that they saw in caffeine group. What they also saw was that the rates of death, the rates of ROP, the rates of brain injury, and the rates of NEC, they did not differ significantly between the two groups. At least they demonstrated that these complications were not higher in the caffeine group. So the complications, these complications, which are death, ROP, brain injury, and NEC, they were more or less same in both groups. Again, as I mentioned, that the death or survival with neurodevelopmental disability was less in the caffeine group with a statistically significant p-value, and similarly, their incidence of cerebral palsy and cognitive delay was also less in the caffeine group as compared to the placebo group. However, the rates of, if we look individually, the rates of death, deafness, blindness, and the mean percentiles for different growth parameters, they did not differ significantly between the two groups. So you can see that the most important and significant effect in terms of the long-term outcomes was on survival with a neurodevelopmental disability, cerebral palsy, and cognitive delay. Few slides about how caffeine works, its pharmacokinetics, and its pharmacological action. So we all drink caffeine, and we all in different forms, either in the coffee or the cold drinks or in the tea, and we all know that it's a wonderful CNS stimulant, and it elevates your mood, and it makes you more alert and more awake. And so the way it works is it's a non-specific inhibitor of adenosine receptors, which are located at multiple sites in the brain. And there are different subtypes of adenosine receptors. And because adenosine is an inhibitory neurotransmitter, by inhibiting adenosine, there's modulation of many excitatory neurotransmitters in the brain and in also different other organs in the body, including lungs, including heart, kidneys. And so some of the facts that I will describe further on, they are basically directly related to adenosine receptor inhibition by caffeine. These are some of the pharmacological effects. It stimulates the respiratory center in the medulla, so increases the respiratory drive and increased sensitivity to carbon dioxide, increased skeletal muscle tone, improves diaphragmatic contractility, increases the minute ventilation, also increases metabolic rate. In the experimental animal models, what they've seen, the scientists, that within minutes of giving caffeine, the diaphragmatic contractility increases quite significantly. And also, if we monitor the CO2 within 30 minutes to 1 hour after giving caffeine, the CO2 levels they start to decline because of the respiratory stimulation and improved diaphragmatic contractility. So there is well-established respiratory effects of caffeine, which have been shown in the experimental animals. Very interesting pharmacokinetics. There is a very clear correlation between the dose and the plasma level, and also between plasma levels and the CSF. So higher the dose, higher will be the plasma levels, and if the plasma levels are higher, the CSF levels will also be higher. But interestingly, the route of administration doesn't affect whether the caffeine is given orally or whether it is given IV. It doesn't. And the absorption is more or less same through the both routes. The peak plasma concentration is achieved within less than an hour. So as soon as we give caffeine, we can start seeing the effect within 30 minutes to 30 to 60 minutes. Now, the interesting thing is that the half-life in preterm neonates is much higher. If we talk about adults, the half-life is only 2 to 4 hours. So we all know that if we have a cup of coffee in the morning, after 3 to 4 hours, probably the effect weans off. But in preterm babies, because of their slower metabolic rate, and the half-life is significantly higher, up to 250 to 300 hours. That means the caffeine stays longer in preterm babies' system as compared to either term babies or older children and adults. In terms of what evidence is there on the respiratory outcomes for preterm babies, we already talked about CAP trial, and there's quite well established evidence that caffeine reduces apnea of prematurity. There is also some evidence that it also reduces the duration and the need for ventilation, and also increases the success of extubation. However, the evidence is not very robust for these two outcomes, and we probably need some more randomized controlled trials to look at these two outcomes, that whether caffeine has any significant effect on the duration or need for ventilation, also whether it increases the extubation success or not. But there's very clear evidence that it definitely reduces the apnea of prematurity. This was a systematic review from Cochrane 2010, and Henderson and colleagues, they looked at methylxanthine treatment for apnea in preterm infants, and clearly showed that caffeine reduces the apnea of prematurity in preterm babies. And they also showed in the same year on a different systematic review that giving caffeine also improves success of endotracheal extubation in preterm infants. But as I said, apart from these two systematic reviews, I could not find any other significant RCTs or any other significant systematic reviews which could show that whether caffeine has any significant effect on reducing the duration of ventilation and also the rates of success of extubation. However, if we talk about long-term outcomes like bronchopulmonary dysplasia and pulmonary function, the CAP trial clearly showed that the BPT incidence was much less and also statistically significant in those babies who received caffeine. This is an interesting study from 2017, and these guys looked at the same population which was enrolled in CAP trial. They looked at their lung function at the age of 11 years, and they showed that all those children who, as a neonate, had received caffeine, the respiratory function was much better in those preterm babies compared to those in the placebo group at the age of 11 years. There's a lot of debate about the timing of starting caffeine, and the current recommendations are that probably should be started within the first 24 to 72 hours. I found this study very interesting because they looked at, they wanted to test the hypothesis whether early caffeine treatment on the day of birth has any effect on CPAP failure or not in the first week of life. And they had a very decent number of neonates, about over 10,000 infants. And what they showed that was whether you give caffeine on the very first day or whether you give it within the first few days of life, in the first week, there was no difference in terms of CPAP failure in the early caffeine and in the routine caffeine group. So this just shows that we probably again need more evidence in this area that what should be the ideal timing for giving caffeine in preterm babies. How does caffeine works on the lungs, and how do we see the improved outcome, respiratory outcomes in preterm babies? So there are three main effects of caffeine on the lungs. It improves the diaphragmatic contractility, also reduces pulmonary inflammation, and also induces surfactant protein synthesis. So these are some of the effects of caffeine on the lungs which have been documented in experimental animals. So moving on from the lungs to the brain. Anyone who works in neonatology, I would encourage you to read this article. Very interesting. So this is 11-year follow-up of the CAP randomized clinical trial. So the same group who initially looked at the CAP trial, they then, after 11 years, they looked at the academic performance, motor function, and the behavior of all those neonates who were enrolled in the CAP trial. Very interesting results, and as I mentioned earlier, there were 2006 infants with a birth weight between 500 and 150 grams, and 11 years after, they showed that the caffeine group had a reduced likelihood of death or clinical disability, and also reduced incidence of cerebral palsy and cognitive delay. So a very clear evidence of improved neurodevelopmental outcome in preterm babies. And I think probably just along with respiratory benefits of caffeine, we should realize that the effects on brain and effects on neurodevelopment are quite significant. And both the short-term and the long-term effects of caffeine on the neurodevelopment are quite impressive and quite significant. On the 5-year follow-up, they showed that there was significant improvement of gross motor function in the caffeine group, and at 11 years, it confirmed the previous results of reduced risk of motor impairment, both with a statistically significant p-value. However, there was no effect on academic performance, behavior, or functional impairment in both groups. How does caffeine improves the neurodevelopmental outcome? There is a dual effect. One is a direct neuroprotective effect of caffeine, and secondly, there is indirect effect by reducing episodes of hypoxia, because by reducing episodes of apnea and by reducing those episodes of desaturation and bradycardia that we see in extreme preterm babies, because those hypoxia episodes are reduced, probably that helps the brain in growth and improves the neurological outcome that way. So there's a dual effect of caffeine on the brain. It increases the respiratory drive, increases CO2 responsiveness, and there's anti-inflammatory, neuroprotective, and anti-apoptotic effect of caffeine as well on the neurons and on the brain cells. Moving on from the lungs and brain to the heart, the caffeine increases the left ventricular stroke volume, and it has inotropic and pressure effect. And again, in experimental models, they've shown that mean blood pressure starts to rise after giving caffeine. So quite a good cardiovascular effect in preterm babies, especially those who need some cardiovascular support and inotropic support. Again, we all know that caffeine has a very good diuretic effect as well. So we see the same effect in preterm babies as well. They have increased urine output, and that promotes diuresis. And there's very then clearly indirect effect on the lungs. Obviously, with RDS, we want to keep the babies on the relatively drier side because that helps the RDS to get better. So giving caffeine promotes diuresis, and that helps the lungs to improve, and that indirectly reduces the lung inflammation, helps the RDS to get better. And I think probably one of the effects that counts how caffeine treatment reduces bronchopulmonary dysplasia is through the indirect effect via diuresis. Anti-inflammatory effects of caffeine as well, and these guys showed in a cohort of preterm infants that all and all anti-inflammatory cytokines like interleukin-6, tumor necrosis factor, and TNF alpha. They're all reduced in those babies who have high caffeine levels. And that explains some of the anti-inflammatory effects of caffeine on different body organs. So moving on, just what is the recommended dosing regime? Obviously, there's different units have different guidelines, but this is probably one of the commonest dosing regime which is used in all the developed world NSUs and also in all good NSUs across the world. 20 milligram per kg as loading dose, followed by a maintenance dose of 5 to 10 milligram per kg. All those born under 30 weeks should receive this, and between 30 to 34 weeks, there's no consensus as such, but all those babies who are needing respiratory support, especially those who are ventilated, they should be given caffeine to reduce the incidence of apnea of prematurity, and also especially if they're ventilated, that would improve, that would reduce the duration of ventilation and improve the chances of extubation success. The timing, again, there is, as I showed earlier, there's still a lot of debate, and there's still no clear evidence that whether early versus early is better or not. But from experience and as you can see that European consensus guidelines and the NICE guidelines, they recommend early caffeine administration, preferably within 24 to 72 hours. There are currently different trials going on which are comparing that giving caffeine soon after birth versus giving caffeine a few days down the line has any beneficial effects or not, and we probably need to wait for the results of those studies. Small babies, especially those under 750 grams, they seem to benefit more from early caffeine as compared to the slightly bigger babies. When can we stop the caffeine? So when the post-menstrual age, anywhere between 32 to 34 weeks, when the baby is stable and there have been no apneic episodes requiring intervention for approximately 5 days, then the caffeine can be stopped. There is very little benefit in continuing caffeine treatment after 34 weeks of post-menstrual age. So in summary, caffeine is now part of standard neonatal care for preterm newborns. It not only reduces the apnea of prematurity, but it also improves extubation success, reduces ventilation days and BPD, and improves the neurological outcome. Has lots of other effects on the heart, kidneys, anti-inflammatory effects on different organs. However, we have to need to understand that that we need more RCTs to further see the effects of caffeine on these outcomes, and also to clear some of the controversies regarding the timing and regarding the dose as well, and also that which one is the most which group of neonates is likely to benefit most from the caffeine. So hopefully over the coming years we'll have more evidence. But as we speak, in January 2022, the caffeine is still the part of the standard neonatal care for all preterm babies, especially those under 30 weeks. I mentioned the dosing regime and the duration. With this, I would like to conclude my talk. If there are any questions, I would be happy to take. And once again, I would like to thank organizers of ICON 2022 and my colleagues at Indus Hospital. Thank you very much.
Thank you very much, Dr. Yasir, highlighting the importance of caffeine. Before we proceed to a Q&A session, I would like to request organizers to please add the speakers live so we can start questions. Dr. Junaid, Dr. Irfan, Dr. Rehan, Dr. Talal.
जी जी
Thank you all. So our first question is from Dr. Yasir, and this question is most probably from to Dr. Junaid. The question is, what is the current recommendation for timing of delayed cord clamping? Is it 60 seconds or 90 seconds?
The current recommendation is 60 seconds. Yeah, but the if the you don't if the baby is very fine in the full term, you can go up to 90 seconds. But the current recommendation is 60 seconds for the those babies, and for premature babies, 30 seconds are fine.
Thank you, sir. Next question is from Dr. Asif Iqbal. The question is, please explain Lisa method. And this question is
Uh,
for Dr. Talal.
yeah. So the LISA is the least less invasive surfactant administration. The actually the what you called the controversies, or to understand or to complicate the mist, or the compare the mist with the LISA. The mist is the minimal invasive surfactant administration, which is you will not use the Miguel forceps. In Lisa, you do the special catheter or the feeding tube through the nose, and then use the Miguel catheter to guide it through the endotracheal tube. This is a little bit difficult method. We are using the mist. We are putting the special catheter. We have it, the Lisa catheter, or the called mist catheter, directly into the endotracheal tube without using the Miguel forceps. So the Lisa is different, which is the less invasive, because you have to use the Miguel forceps. The mist is the minimal invasive. I mean, it's a little bit different, but it's a minimal invasive, where you can directly put the feeding tube or the catheter, which is developed by the Curosoft company, KIC pharmaceutical, into the trachea through the ET tube.
May I just add one thing?
Sure, sir. Sure, please.
Absolutely right. Thank you very much, Dr. Junaid, for highlighting this point. The only thing is we are using it in a spontaneously breathing baby. That's the most important thing. We do not need to intubate the babies. Endotracheal tube is bad. Even 5 breaths which you give without a manometer, they can damage your
Yeah.
alveoli. So the only important thing is that you're using it in a spontaneously breathing baby. The distribution of surfactant is far more homogeneous when you do Lisa, and as I showed you the graphs also, when you do Lisa, less number of babies required long-term oxygenation, less number of babies when compared with controls required intubation and ventilation. So
Yeah.
that's the bottom line to the whole thing. Whether you use Lisa, whether you do mist, you're doing it in a spontaneously breathing baby without intubation.
Thank you so
That's
much,
all.
sir.
Thank you.
Um, our next question is from Dr. Sanagar Ali, and he asks, what do NRP guidelines say about suctioning of babies with meconium aspiration?
So as I mentioned, it is before what we are doing, which is the 2015 guidelines, that we shouldn't do any section in any sort of the meconium, non-vigorous or vigorous, no matter. Because the thing is that the chances to delay the PPV or delay the oxygenation of the baby is very high, and it is more dangerous. So whatever it goes in, even you do that several endotracheal tube section, it will not come out. So it's better to start the oxygenation right away and forget about the sectioning through the ET tube. So this is the thing, that we shouldn't do the endotracheal sectioning in meconium aspiration of any kind, thick, thin, or whatever.
Thank you so much, sir. Next question is from Dr. Navi Durani, and he asks that at what level of CPAP, 5, 6, or 7, with FiO2 more than 30%, to decide surfactant?
I've
Dr. Dalal.
already answered him in the chat box, but yes, I'll explain it a bit more. Nobody actually knows it. All the trials that have been done, nobody has measured the CPAP level as such where CPAP failure starts to take place. But yes, the most important thing is you need to recruit the alveoli, you need to recruit the lung. And I think with a CPAP level of maybe 7 to 8 would be enough. But yes, even the latest Optimist trial that has taken place, the caveat to that trial is that the 33 centers which took part in it, none of them measured what CPAP level they defined as a failure. So it is more important that we concentrate that once the alveoli have been recruited, we have an adequate CPAP of probably 7 could be a good take, or maybe 8, and the oxygen requirement is going up more than 30%. We need to think about surfactant. So I hope
Faraz,
nobody knows. Yeah.
yeah, I want to add one thing that
Sure, sir.
in one of the IndusWeb seminars I showed that we are doing the study. Actually, we are the part of this is the international studies with the Mayo and all those bigger centers. They are seeing in the low CPAP group and the higher CPAP group, and there's a full criteria. It will come like 1.5 to 2 years from now, the results of, and then it can what Talal is saying is too much, is very much right, that at this point we don't know. But I just want to add, never start less than 5 in any
Yeah,
baby.
certainly. Certainly.
Any
Certainly.
baby.
That's no CPAP
Okay.
at all. That's no
And
CPAP at all.
other the maximum you as Talal said, don't go beyond 8. So that's why our this is our practice, our criteria. If it is 40% and above and requiring 7 and above PEEP, or the PCO2 more arterial is more than 60, we give surfactant, and then by MIST technique, and then we will see how the baby is doing.
Now, doing arterial gases in Pakistan is difficult, and people don't have much facilities. So I'm absolutely right. Internationally, that would be there, but for Pakistan, I would recommend go with FiO2
Sure,
and a
sure.
CPAP. Bubble
Yeah,
CPAPs are very cheap. You can use it. So that's the take home thought was that do surfactant. That's fine. Surfactant is important part of the whole package that we have. But in that package, if we do not have CPAP, the package is useless. We'll
yeah.
be probably
So
wasting money.
So I put in the comments also somebody asking about that the CPAP, if we have command on the CPAP and the antenatal steroids, which is very
Yeah,
cheap to 100% of the mothers, believe me or not, we are hardly using surfactant. So no need to sell the bike to get that expensive medicine. No need for that.
absolutely.
So
Yeah,
CPAP is the mainstay. Irfan is not there. Irfan said that you can start with the, but less than 32 weeks. The primary mode is the
is
CPAP,
CPAP,
not the high
not
flow
high
nasal
flow.
cannula. So, with due
Absolutely.
respect, with the Irfan, if he's listening to me, if I'm correct or not. Rehan, you have some
Absolutely.
comment on that
The take
because
home
when I
message
did
was we need CPAP.
exactly. So, Rehan, when I did round with you, you also have similar kind of a situation. So, can you comment on that? Or
Dr. Rehan.
I think he.
I think his internet is a bit dodgy.
Yeah.
Yes, sir. There is
Okay, you
internet
go
I've
issue
ahead,
just
from
then
his
he
seen,
will
side.
come back.
I've seen
Uh,
places where I've seen cases, and I've seen places, and people have been discussing it with me that okay, we are using surfactant, we give 20 surfactants a month, and if I ask them, do you have effective CPAP in your place? No, we don't have it. So
Yeah,
that's not the way
exactly.
forward. That's not the way forward. That's what my whole point was, hampering upon the point that we need CPAP. And
100% agree with you, Talal. 100%. So this is the thing. Go ahead, Faraz.
Thank you, sir. Our next question is from Dr. Bashir Abro. Can we use caffeine in apnea of mature babies? And what is the duration of treatment in these babies? Thanks.
Yes, sir.
Dr. Yasir, can you answer this question?
His voice is not
Yeah,
connected.
I guess there is internet issue from his side. If any other speakers can answer, Dr. Junaid or Dr.
I
Talal.
think we don't have any studies in the mature babies, and the reason because of the time, I think Yasser missed it. The main thing in the premature baby, why they have the apnea, that the sensitivity of the PCO2 to stimulate your respiration center is very, very premature. You all know that we need a carbon dioxide in our body to stimulate our respiratory center. If we, let's say, if from the animal we did the study, we remove all the carbon dioxide, they become apneic right away. So in the lab, we remove all the carbon dioxide. So there is some quantity of the carbon dioxide should be remain in your body, and this is the reflex which the premature don't have. And this is the main thing what caffeine is doing to increase the sensitivity of the carbon dioxide. Now this is not happening in the adult, I mean not in the adult, I mean in the full-term baby. Somebody asked me about the HIE also. So same answer. The caffeine has no role in the HIE and the full term. This is my
No, no.
opinion. Rehan is here. Talal, you can.
Yeah, I 100% agree with you, because you need to look at the cause of apnea in a term baby. If he's having apnea secondary to hypoxic ischemic encephalopathy,
Yeah.
he might be seizing. These
Yes.
apneas are actually seizures. So caffeine is not going to help at all. It's not a drug that's going to help at all. So you need to see what is the underlying pathology. In a pathology in a term baby is far different than that in a preterm baby. So I
Exactly.
agree with Dr. Junaid. The role is the minimum role. Rather, we haven't seen
Yeah.
any papers on it, but I don't think so. There is a role.
And you know, Faraz, as Talal said, if the baby starts seizing and is on caffeine, then it makes the situation worse. Okay.
Right, sir.
Yep.
Yeah.
So I guess the next question is in the same context. It was about role of caffeine in HIE in full terms. I guess the
Yeah. We
answer has
answered
been
this
given.
question.
So our next question is from Dr. Naveed Durrani, and he says that I have seen physicians are sending babies home on caffeine. Do you think this practice should be stopped?
Yes, it should be stopped because caffeine half life is what is our practice is to again, with due respect with Yasir, we are taking over his questions. But anyway, me and Talal is only connecting right now. So Talal, also your comment. So we stop caffeine and we wait for 5 days because you know the caffeine half life is very, very, very big, and then
And you
because the
know,
rebound apnea can happen. So this is our practice, but Talal, you comment according to your
yes,
practice in
surely.
medicine.
Surely, I think I agree with you, and I think you anyway won't send a less than 33 weeker or a 32 weeker home.
Exactly.
So once you are beyond that period of 33, 32, 34, 34, 33-ish, I think you need to stop caffeine. The baby is not on oxygen. He's not capnic. He's not having apnea. You stop caffeine. You can wait for 3, 4 days and then send him home without it.
Yeah. The question is because Indus is sending the baby very, very small,
Yes, sir.
premature age. So if you have to send, that's fine because of the place and because of the occupancy, but stop caffeine before that. Okay.
Yes.
That's a little bit.
I'll answer one of the questions that's very important. I think Imran has asked.
Mhm.
Most babies place most of the places bubble CPAP are self-made by normal saline drip. What are your recommendations for this sort of CPAP? Yes, this is a very important question. This sort of indigenously made, what we are trainees sometimes call desi CPAP sort of a thing, is good. No doubt it is
Yes.
good. But please remember, one thing, you are using oxygen only. If you can make a T connector and make it with air and oxygen, plan a. I can show it sometime later. I have those flow meters in my unit where we've used the two, and you can have an air cylinder with it. It's very good. But the problem is this: if you're using it without an air cylinder, we do not have blenders in Pakistan, then you are giving 100% oxygen at a high flow rate. Now, that may be detrimental itself, and you can't keep it for a long period of time. You may use it for a little bit of transport, Imran, but using it for a long period of time, non humidified, non heated, oxygen only is very toxic. So,
So
Dr.
I
Junaid,
think
you can add a couple
I
of
think
things in.
what Talal tried to say that if you have some money, some budget, please don't spend on surfactant, spend on a blender. Okay, so if you don't spend on any high gadget, blender is a very if you know the Karachi where all the old cars mechanic shesha, they can make it in very small because it's nothing, it's just a mixer. Okay, and it has to be very cheap, but I don't know what is the price. So please, to all those who are listening who don't have the blenders, if they have any budget for their unit, please try to spend on the blenders as compared to anything else.
डॉक्टर जुनैद, जब तक ब्लेंडर हमारे पास नहीं है, हम जो फ्लो मीटर है,
जी जी
if you
जी
दो फ्लो मीटर्स को we connected with a, I can post it somewhere on the group if you people want it. I have it in my unit. We have two flow meters. We have connected them through metallic. We told
जी
one of
जी
the
जी जी
iron
वो तो
person.
टी कनेक्टर
उसने
है.
जी उसने हमें बना दिया है, and
हम्म.
now we use the flow to manage it according to the finest formula, or the वो एक there's a graph available that if you keep 1 liter from here and 1 liter from here, approximately इतनी मिलती है. But that's
Yeah.
the only thing. Yes, indigenous CPAP is very good. It's life saving as long as you know this thing. As long as you know this thing. That's all. जी फराज.
हाँ, थैंक यू ऑल. अब और कोई सवाल बाकी रहा नहीं है, तो आई वुड रिक्वेस्ट डॉक्टर रेहान फॉर हिज वोट ऑफ थैंक्स.
I don't know if you guys can hear
जी
me.
सर,
I'm
you're
having
audible
some
clearly.
difficulty with my internet.
Sir, your voice is audible.
I mean,
I guess there is again an issue with the internet. We are trying to connect with Dr. Rehan. I think we can take him on call. Just give me a minute so that I can take Dr. Rehan on call. There.
Until you are connecting the Rehan for us, there's some.
Yes, sir, I have taken Dr. Rehan on call.
Okay.
Can you guys hear me? Yeah, I definitely.
I think he has.
Now people have started. Now people have started tolerating us. I mean, looking at what Junaid
I don't
has
think
to
he's
say,
audible.
I wonder what Waqar has to say next year for us, because they kept changing the recommendation every year. It will be very difficult, what they will come up with the next recommendation next year. In terms of Talal talk, what I can say is, I mean, what's there for us when this antenatal corticosteroid and mother care and all those things happens uniformly in our setup. I'm very excited at Irfan's talk because this is what I've been using in my unit with great success. I mean, as I said, guys, I mean, we have set the stage and it's all up to you guys, to spread your wings, feel free with the free will, but again, with the caution of evidence. Again, caffeine is very promising, and this is not the last drug. I mean, there are many more to come as well. Again, we all know the situation in Pakistan. There are dilemmas since the decision of devolve health ministry from federal to the provincial level. I mean, again, these have some opportunities as well. So we all should think positive and try and do things what is right for the population which is in need. I thank you very much, all of you, for your time and commitment. I mean, obviously, we hope to see you all in our next icon. Thank you very much for all the speakers who have taken their precious time and given us some time in our icon 22.
Thank you very much. Ji. Thank you very much. We're very grateful.
Thank you, sir. Thank you. With this, we conclude our session. And as Dr. Rehan said, we are very delighted to have speakers, and they spared spacious time from the busy schedule. And thank you all for your attention. Allah Hafiz.